because we're covering the digestive system. And so how we've kind of broken up the PowerPoint is we're going to do the gross anatomy today, and then we'll do the histology stuff coming up next time. And then review and then exam will be next week. So for the gross anatomy, a lot of it could maybe potentially be like one of those posters, maybe that digestive system poster, maybe one of these boards, or even something like a liver that's just kind of set up by itself. So when you're focusing on that gross anatomy, kind of focus on some of that stuff. And so thinking about digestive system, we kind of have to cover a lot of area, right? We have to talk about the oral cavity, the teeth, salivary glands, esophagus, all the way down through stomach, intestines, etc. But when we do digestive system, we also kind of sort of remind ourselves about respiratory system, because we have kind of a little bit of an issue when it comes to thinking about that foods and liquids are going to be moving into the shared space of the oropharynx. And so then you'd have your trachea kind of sitting here right in the front, and that you don't want foods and liquids to go down the trachea, so there's these structures that we're going to have to kind of prevent that. I had a rice cake before I came in for a snack, and I'm like, and then we also need to block off the nasal cavity, right? Because we also don't want to have a bunch of stuff moving up inside the nasal cavity. So we'll kind of go through all those pieces, parts, but then you've also got some accessory organs like the liver and the pancreas, that's not just a part of that tube, right? If you were to kind of follow from your esophagus all the way through to anus, it's kind of one big giant tube, sort of going all the way through that, but then some of those other accessory organs. So saliva, super important part of your digestive system. Kind of one of its important aspects is to make sure we're keeping that epithelium moist, right? Because it's your non-keratinized type, so it's not like your skin. But you also have to think about maintaining the correct pH of the oral cavity. It's good for the microbiome. It's good to kind of wash particles away to keep those bacteria from like metabolizing and making a lot of acidic components, because that acid is going to change things in the oral cavity. That's where you're going to start to get cavities in your enamel. So if that pH gets off, you can start to erode that really super tough substance. So we got to make sure that we also keep that pH right. And we're also going to be putting in some digestive enzymes. Okay, some will be active in the oral cavity, others are going to activate once they make their way down into the stomach, so it just depends. If you're talking the glucose ones, the amylase, okay, that'll activate for certain carbohydrates right there in your mouth, but then the lipases won't be active till they get to that acidic environment of the stomach. And so thinking about these salivary glands, okay, the parotid is going to be one of those that doesn't really match with the location, right? So the parotids are going to be kind of right here, kind of right down from the ears, and then these other two, you have to use your Latin roots, okay? Thinking about what sub means, it means underneath, so sublingual, which means under the tongue, versus submandibular, okay? Because they're kind of in the same region. But if we were to kind of take this jawbone and move it and have it, you know, in place, that sublingual is going to be like if you were to lift your tongue up and peel some of that tissue back from right on the bottom of your mouth, that's where the sublingual salivary gland would be. Then you get to your mandible bone, and then if you were to peel the tissue back down here, right, your skin and some of that muscle, then your sublingual salivary gland, or your submandibular, is going to be under here, right? So there's one under the mandible, and then there's one on the top side of the mandible, but under the tongue. So just kind of be aware of that. So using a picture like that, there's the diagram up there where it's got his face. And so it kind of starts with the salivary glands. You can't really see much else with that poster. So kind of refreshing from 209. Okay, when you guys were doing respiratory system in 209, and you were learning things like the hard palate and the soft palate and all of that, the poster that they used was the sagittal cut, right? Which looks really different from this one, right? So usually when you're seeing hard palate, soft palate, you're looking at it from the side, and so you've got your bone that kind of comes here, and then the soft palate, it just kind of shows it as doing this, right? And then you've got the uvula part that kind of dangles off the bottom. But what you miss by looking at that from a sagittal cut is you actually miss how wide these hard and soft palates actually are. So the bony pieces that's right up behind the teeth, and there's the two bones that make up your hard palate, okay? And then down here, stretching all the way from here, all the way through here, all the way over to here, that's the soft palate. Then you've got the uvula that dangles down off the back, right? So it's a little easier for me, for this viewpoint, to kind of mark all of the soft palate versus just the uvula, right? It's a little bit easier to do it from this way than from a sagittal cut. And then kind of looking at our teeth. What's really cool is if you kind of get into the dentition of things like carnivores versus omnivores versus herbivores, and then think about how those teeth are similar versus really super different, right? And also thinking that even us as omnivores, we don't have the exact same dentition. Like if you were to look at a human jaw versus a bear jaw, I mean, there's gonna be some similarities, but even like wild animal omnivores are gonna have much bigger canines than what we do. Even primates, you're gonna have really super big canines, right? Humans have little wimpy canines unless you're a vampire. And then they grow, right? Then you get big old canines. But our teeth have to be able to deal with vegetable and meat, right? So the teeth kind of here at the front and then back to the canines are gonna kind of come up to a point like this. Okay, and granted, they're not super sharp. Like if you look at your cat's teeth, it looks like the Himalayan mountain range, right? They're like little knives, okay? But your cat is eating pure meat, getting through skin and tendons and ligaments and just ripping things, right? So they gotta have really super strong teeth. We have kind of wimpy teeth now. Okay, we're not running around, I mean, unless you're a zombie human, you're not like ripping into live flesh. Like it's cooked and it's all soft and, you know, we tend to cut off the rough parts and all that stuff. So, like our incisors, okay, these beginning teeth here are kind of like little knife edges, but not super sharp like you'd see in other animals. And then you come off to the side, and what you're gonna start to see is you kind of start moving backwards. You're gonna start to see more flatter surfaces coming in. So even if you look at the canine, it's got that little pointy piece here, but then see toward the back, it's kind of getting flat a little bit. And then once you make it to the molars, now see how flat everything is. It's not coming like a little point, it's kind of doing like this. So that flat edge is gonna be for kind of grinding and kind of tearing into stuff, you know, plant material, whatever. So even if you're talking about herbivores, so if you've ever found a jawbone or you've looked at like horse teeth, cow teeth, deer, etc., their molars look a little different than ours, okay? Even though they kind of have this flat surface, like even ours is not, like our molars don't just go like this, right? They're not totally completely flat. Our molars kind of come up and they got a few little bumps, okay? But nothing super big. They're not super duper sharp. But whoa, if you ever get a jawbone from like a deer or an elk or something like that, and their freaking molars are gonna be super jaggedy, right? So even that flat surface is gonna have some pretty sharp points to it. But deer and elk and animals like that, they're not eating soft little lettuce and spinach and, you know, bell peppers. They're eating pretty harsh vegetable matter and getting into the bark of, you know, bushes and things like that. So they've really got to get in there and grind all that stuff up. We don't quite need as much, so our little surface can be just a little bit flatter in our teeth. And so in your guys' lab book, it talks about something called the dental formula, okay? I won't ask specific questions about that on an exam, but knowing the numbers of the teeth in a quadrant is going to help you to identify the type of the tooth, right? So when you see those numbers, they're talking about just 1/4, right? And then if you want to know all the teeth in a person's face, you just multiply that by 4, okay, to kind of figure that out. So a dental formula says that you've got 2, and we're talking an adult, I'm not going to do, you know, child stuff, but you've got 2 of the incisors, and then moving backwards, we've got 1 canine, okay, so that dental formula would be 2, and then a 1 for the canine. Then the next set is you start really getting flat, so you've got 2 of the premolars, so they're just a little bit smaller, and then as you move way to the back, you've got 3 of the actual molars, and see how much bigger they are. And now you're way clear at the very back, okay. Most adults' dental formula is not going to be 2, 1, 2, 3. It'll be 2, 1, 2, 2. Okay, so what's the name of that third set of teeth that most adults don't get to keep because your mouth is not big enough? That's your wisdom teeth. Okay, so where this shows the 1, 2, 3 molars, most adults are not going to have that third set. Okay. Most of us keep our teeth all the way into adulthood. Unless you lose one of your other teeth, you don't have enough room in your face. Okay, and so having wisdom teeth come in, if any of you guys have ever had to have them removed, it's kind of a pain in the ass, right? They can cause a lot of pain. They can come in and start pushing some of your other teeth out, or what they did to me, so I had mine removed when I was like 19-ish, there was literally no room to even partially pop through the surface. What they started doing is actually growing sideways and pushing all my other teeth forward on both sides of my jaw. So they basically were coming in and shoving all of these this way and all of these this way. So I was dealing with full jaw pain. There was like no localization to it at that point. It was just cramming and like shoving all my teeth together. So when they went in to remove mine, they had to come and cut. Okay, imagine that he's really not even popping up here. They had to kind of cut through my gums and then break the tooth up into little pieces and then extract the little pieces. And the reason why they have to do that is because the roots of your freaking tooth are like this. Teeth are horrifying. They're freaking horrifying. I hate looking at teeth out of a human body. It's effing gross. It's so gross. Because this is the part, and then you're like, this is what's in your face. This is all in the bone, like anchored in there. So trying to pull teeth, I mean, most people are not awake maybe, or you're on so many good drugs you don't give a crap. But it is a rough procedure to get teeth pulled. I mean, they have to get in there and crank it, like rip things out. Unless you've got really loose teeth, it's not an easy endeavor. Well, mine were so problematic and kind of coming up underneath some of my other roots of my other teeth that they had to break them into pieces and extract them. And then I ended up getting dry sockets. I did all 4 at once. They told me I had a choice. I'm like, huh. They're like, you can do these 2 and then come back in a while and do the other 2. I said, or you can do them all at once and put me under general anesthesia because I'm not coming in and doing this shit again. Like, no. Do them all, I'm not doing this. So I ended up with dry sockets and had to like rinse out the open holes and everything. It was pretty miserable. It was about 3 months before I could end up actually eating. Like the first time I got to have a steak after that, oh, I thought I was in heaven. I was like, oh my God, because it hurt so bad to chew things, it was terrible. So most people don't get to keep those wisdom teeth, right? So the only reason why that dental formula is kind of nice is because on an exam, whether it's upper or lower, if I circled one of these tooth types, especially if it's the premolar molars, you might want to do the little count in your head and find where your incisors, find your canine, and then, because, you know, if I'm circling like that second premolar, you're like, oh shit, was that my premolar or my molar? You can sometimes go based on the size and figure it out, but for some students, just knowing that dental formula is just that little bit that they can do on an exam. But I don't ask any kind of specific questions about it. And then just kind of interesting looking at the difference between like your primary teeth versus adult teeth. So one of the things that happened to my youngest sister is that she kind of inherited like a small jaw from one side of the family and big ass teeth from the others, like big ass adult teeth. So when her adult teeth were coming in, she didn't have enough room when her baby teeth would fall out because they were so precious and so tiny that when her adult teeth were coming in, they were coming in all crooked. So every single time she had a tooth coming in, she'd have to go to the dentist and get the next one back pulled out to make enough room. So needless to say, she does not like going to the dentist. She has a lot of trauma and a lot of like, you know, a miserable experience for doing that. So many times when she was having to go into the dentist, they were worried that actually they were thinking I was gonna have to have braces. So if you look at pictures of me when I'm a little kid, I got a huge gap in between my 2 upper teeth, huge gap. Like I could literally take a pencil and like stick, which was not safe to do. We were dipshits back then. But stick a pencil in that and like wave it around. It was really dumb. Like don't ever do that. But my dentist at the time told my mom, he's like, you know, she hasn't lost all of her baby teeth yet. Let's hold off. Because it might be that when her teeth come in, it'll correct itself. Lucky for me, it did. So the youngest sister though, just because of having to pull all those teeth, the rest of them were kind of coming in, so she ended up having to have braces and all of that stuff that she had to do, so I got pretty lucky. So now kind of looking at the tooth, right? So the crown is the part that you're seeing when you're looking at somebody's teeth, but the biggest bulk of your tooth is actually embedded in your jawbone, the maxilla or the mandible, right? And so there's a lot of complexity that sort of comes into how that tooth is actually anchored into that jawbone, these different specialized connective tissues, we call it the periodontal membrane and all of that, because you really want a super tight seal. So if you notice, this little piece that's right here, and then all those little white fibers are really strong connections to hook that tooth into that jawbone, right? So as long as all of this remains intact, your teeth are going to be solid in your face, right? They won't really necessarily fall out. The problem comes in is if the gum tissue does what they call recession, which means it pulls back, and instead of being super tight up against that enamel, it starts to peel like this, and it peels back, okay? And so now all these bacteria that should only be on the outside of that enamel, that white part, they're getting access down here to this part. And if they start to erode that periodontal membrane, now your teeth are going to end up getting loose and you're going to have periodontal disease. That's where that comes from. So those bacteria get down in there and they have all these metabolites and they're going to start to erode away. But what's crazy about it is that dentin, which is this orangey layer that kind of comes all the way down into the roots, even this layer is stronger than the jawbone. So what usually ends up happening is that the jawbone erodes, but the tooth stays intact. But it's still going to be loose in that person's jaw. So what's crazy, the enamel and the dentin and the bone, okay? So this part out here would be your compact bone, and then you've got your spongy bone on the inside. They're made of the exact same material, pretty much. It's the hydroxyapatite, which is calcium, phosphates, and magnesium. The difference between these, what's your percentage that you've actually got of those hydroxyapatite crystals? So the enamel has the most in the human body. This is the strongest substance. Then dentin, then bone, right? And so there is some water, which doesn't seem like that. It doesn't seem like your bones would have water, but your bones are gonna have some water. There's also some collagen, okay, that's gonna be in there. But the biggest bulk of that enamel is that hydroxyapatite crystal. So notice all of this. See how we kind of have these little dips and valleys in here? Like it doesn't just go straight across, like it kind of dips down just a little bit. So imagine down inside one of these little grooves, you start to get some bacteria that are kind of hanging out and forming like a little biofilm, right? If you don't get that cleaned off, if the pH gets really acidic, that's going to start to erode that enamel. Strong as it is very susceptible to those changes in pH. That's one of the jobs of saliva, is to try to keep that pH closer to neutral so you're not getting super duper acidic. So in my molars on the bottoms, like I want to say like right around here, I had these little teeny tiny holes. They weren't going all the way into the pulp, but they were still, and it's something that was genetics. It was on the same tooth, lower and upper, in the exact same spot. So they filled those in when I was like in my 20s. They're like, we'll just grind them out just a little bit and we'll put fillings in it, because my dentist was like, that's gonna be an issue. That if they're moving their way on the inside of those holes, you won't be able to brush that stuff out of there. And you're gonna end up getting bacteria lodged kind of inside here and starting to form a cavity deep inside here. So they just ended up filling it up and just making it the same level as what the rest of the enamel is. So that kind of orangey where you see the blood vessels and the nerves, that's the pulp, okay? If you were to look at that in a tooth, it resembles what the red marrow was, like kind of wet and goopy and thick, right? And so what we have down here at the bottom is blood vessels and nerves feed up through these little foramen, up through the roots. So this is the part that if you end up having tooth pain, you're activating those nerves, right? And so if you end up with a cavity that's only going like down to here, you're probably not gonna feel anything yet, right? Because it hasn't gotten to the peach layer. It's once it breaches into that peach layer, now it's gonna start to hurt. But if you're getting regular visits to the dentist, and you notice that what they'll do is they'll come in there and they kind of poke that surface, that flat surface of your teeth, they kind of poke that. They're looking for squishy spots, which indicates that you've got a cavity potentially forming. So that's why they push down, is they're just looking for any spots that are kind of squishy. Oh shit. And the other thing that they'll check is that they take this little probe, it's a lot thinner in real life, but they take this little probe and it's got these different measurement lines on it. And they're gonna go around your teeth, and they can do it super quick. It's almost like they just kind of, and they put that little probe between the gums and the enamel. Because what they're looking for is that recession. It is it peeling away from that enamel. So having a shorter, like if it only drops in that far, you're totally completely fine. That's completely normal. But if they're putting that thing around your gums, and it disappears down to there, then that could indicate you've got early periodontal disease or something like that. And if it peels away bad enough, you have to do what's called the deep scale cleaning. So they have to actually go in there and get in between your tooth and the gum and scrape all of that plaque out of there. It's not a super fun experience. But if they don't, you're just going to end up eroding away that periodontal ligament and then the jawbone. Okay? So if that periodontal disease gets really, really bad, and what you'll see in patients that have really bad periodontal disease is the gums are basically disappearing. They're pulling back, and you can actually end up seeing part of the roots actually popping out, right? So you definitely don't want that. And so what's cool is if you start kind of looking at the complexities of the human jaw, and this is kind of why we get into learning parts when everything looks the same color. Arteries, veins, nerves, like they're all that kind of off-white. So you're like, oh shit, okay, well, what would that be? Well, you'd want a surgeon damn sure knowing what that is, right? So they're not in there dinking around and cutting things or doing whatever. Or if they need to numb your jaw, they need to go put it over the nerve, not a blood vessel, right? So it's just really cool to look at the human jaw and to see how the nerves and the blood vessels kind of trace along and go up into those foramen and feed into the teeth. And then if you ever need to do like a root canal, if you get an abscess, right? And so, I mean, pets can get abscesses a lot of times, like your cats or whatever, they'll get scratched and they get like the big thing that kind of pops up. Abscesses are really notorious for being difficult to treat with just antibiotics. It's almost like it kind of walls itself off from the vasculature and everything else. And so a lot of times you have to drain that abscess, right? You have to go in, kind of pop it, drain it surgically, and then even try to remove, because a lot of times the abscess will have this really hard connective tissue covering around it, and you want to get that out of there. A lot of times if you don't pull the capsule out, it just ends up coming back. And so you end up having the same issue. So having an abscess way down deep in the root of your tooth is going to be a little bit of a problem, right? It's definitely not optimal. So in this case, they go in, they drill the crap out of the pulp cavity. You're not awake at this point, right? They drill the hell out of the pulp cavity and basically kill the nerves and the blood vessels, okay? And then they're going to come fill this in, and then they're going to put a little filling in it, and then they're going to pop the crown over top of that. And that crown needs to match what the other one looked like so your teeth come together right. You don't want them grinding and rubbing and scraping in the wrong way. So sometimes if people get that crown put on, they may have to go back to the dentist and get it kind of reshaped. So there's a little bit of artistry that kind of goes into creating stuff like this. It's kind of awesome. So kind of reminding ourselves about respiratory and then oral cavity, right? Because we kind of have two different body systems that are using a lot of these same areas. Okay, so we've got the oral cavity, you've got your nasopharynx, the oropharynx, etc., trachea in the front, squishy little esophagus coming down the back, right? You see that hard palate is the bone. All of that tissue would be the soft palate, but you're only seeing just part of it. You're not seeing how it moves to the side to come all the way out here. And then just the tip, that's the uvula, right? So oral cavity meets respiratory. And remember that little epiglottis, part of which is attached to that hyoid bone, that when you do the act of swallowing, that makes that close off, but it also pushes the soft palate backwards to seal off the nasal cavity. So in that way, things are only moving down into that esophagus, exactly where you want it. And look at how little that esophagus is. It's super duper small, right? It's super squished. It gets squished right between the vertebral column and the trachea, right? So one of the also jobs to think about with your teeth is to be able to grind that food down to a really soft consistency to make it a lot easier to swallow. And so looking at actual human cadavers, like being able to see how much the tongue actually takes up of the oral cavity, right? So it's a little hard to see that it's an open cavity. So here's a cadaver that has the mouth kind of open, and so you can kind of see that. You've got your little nasal concha, and I love this because it's got the braids. You can see that septum pellucidum that separates the ventricles. You've got part of your dura mater. You can see your spinal cord kind of coming down here. But there's the little esophagus, like getting squished right there. Oh, and because we're going to be talking about sphincters that are going to be kind of closing off certain parts, your upper esophageal sphincter will be the one. So you see that little bit of muscle that's right here, and then part of the muscle that's back on that body part, that body wall, that's going to be your upper esophageal. Okay, so now your lower esophageal is going to be the one between the stomach and the esophagus. So thinking like this, right? So here it shows your epiglottis, and then your uvula shoved all the way to the back. Nothing gets up into the nasal cavity, nothing gets down inside the trachea. So we want that nice little bolus to go down the esophagus, and then you've got the peristalsis moving, and we'll talk about the muscles when we do the histology stuff that we'll do next time. And then you've got your lower esophageal sphincter right before you get to the stomach. That's the one that fails in gastroesophageal reflux, that allows that stomach acid to keep coming up and just burning the hell out of your poor little esophagus. So right where that little cardia region is, that little kind of black box, that's where your lower esophageal sphincter is, kind of right in that area. Then your stomach has this piece called the fundus that they can, if you have gastroesophageal reflux and it's not well controlled with medications or things like that, they can actually go in and create a sphincter by wrapping that around the back side of where that esophagus comes in and then suturing it in such a way that it allows things to move into the stomach but won't allow anything to come back out. So that includes vomiting. So people that end up having that surgery, if they end up getting a foodborne illness or some other kind of sickness, if they drink too much alcohol and they can't vomit, it can be life-threatening. They'll have to go to the hospital and have their stomach physically pumped out. So it's a gross thing and nobody wants to do it, but if you think about it in terms of just what it's trying to do, it's trying to get rid of this poisonous alcohol, it's trying to get rid of all these bacteria or these viruses and all these toxins, right? And so if you can't do that, it just ends up overwhelming your immune system. It can actually kill someone. So now the biggest part of your stomach, that's the body, and then what we let you guys do, just to make it a little bit easier, see where you've got like these two different regions that they've got circled in that black? Everything in the red though, we'll let you guys just call that the pyloric region. Just keep it like that. Because then what that does is this piece popping out here is actually the first part of your small intestine. It's called the duodenum. So then this sphincter is your pyloric sphincter. Okay, so that's what's going to really control how much of that really fluidy, acidic kind is actually making its way into your duodenum. So you just want to make sure that that sphincter doesn't just open like a floodgate and then bam, like all of this liquid just pours into that duodenum. It's really acidic. So we have to control how much comes in, and literally right here is where you get the bile and then the pancreatic juices coming together, and that's what's going to end up neutralizing that. So this big piece, that's our greater curvature. That's where your greater omentum attaches, that big kind of adipose flap that's going to cover up all your intestines. Lesser curvature, lesser omentum goes from there and then comes up and attaches to the underneath side of the bladder. So where we talk about like our portal vein and all of that, that vein is going to be found in that connective tissue, in that lesser omentum as it's coming in from your intestines. And we'll talk about the muscle layers once we get to the histology part, but esophagus, all of the small intestine, all of the large intestine, there's 2 layers of muscle. Stomach has 3. So it's got the same 2 as everywhere else, but we're going to introduce a 3rd one. But we'll cover that once we get to the histology. So on this one, you can kind of practice, okay, yeah, there's my esophagus coming in. Go through all the parts of your stomach where it would be your lower esophageal sphincter, your pyloric sphincter. But notice here that with that first stretch of the duodenum, most of it's going to be up and behind where your large intestine actually is. So there is so many different layers to all these organs. We look at this one, which is kind of more superficial, then you're not even going to see the pancreas yet, right? It's going to be up and behind all of that stuff. It'll be tucked behind your stomach and then your large intestine. So the bulk, kind of the middle part of your small intestine is the jejunum. And then as you start making your way getting into the large intestine, now it's the ileum. Spelled just a little different than the ileum, that's the bone. The bone is IUM, intestine is EUM. So that's just a difference in that spelling. So if you open up the small intestine, see how it looks like a little t-shirt that's been kind of crinkled up a little bit? Those are called circular folds. And then you can also see the villi that would be poking off of those if this was like looking in there with the little camera and it was all wet. You can also see the villi if they're microscopic. Right, so the big fingers poking out would be your villi. And then remember, because I'm not going to draw this, it takes too long, those black lines that I drew are actually simple columnar epithelium, right? We go all the way around, and then on the ends, coming out of there would be your microvilli that you can see if you're looking through an electron microscope. So everything about your small intestines, gobs and gobs of surface area, like huge amounts. okay? And even though your small intestine is going to secrete some digestive enzymes, most of the digestion to get us down to our building blocks is happening from our pancreas, not from your small intestine. So now coming into large intestine, so there's just a little piece of the ileum, the rest of your small intestine's now gone. So now we need to have another sphincter to separate small intestine from large intestine. And where the name comes from is that little pouch that kind of dangles down right here is called the cecum. So that sphincter is kind of a combination of those two words, the ileocecal sphincter. So also keeping in mind that the pH in our different regions of the colon will be different, but even the microbiome is also going to be different. Yes, there's some similar strains of bacteria, but there's also some differences as well. So it's also going to kind of help to keep the different components of the microbiome where they're supposed to be. And so if we notice with our small intestine, like, yeah, it's got some wrinkles in it, but it's relatively smooth, right? And now if you look at your large intestine, it's got these little bulges to it. So those little bulges are called haustra. And then you've got, in addition to, so in that pink line, okay, there's going to be epithelium, there's connective tissue, there's muscle layers, we're going to talk about that. But then this muscle that kind of runs right along here is going to be working to kind of squish those haustra and then move what's going to be fecal matter eventually up the ascending, which goes up this way on the right hand side, and then it goes across, so remember transverse, right? Trans is across, and then coming down the descending, and then this stretch that only comes to about the belly button, okay, that's your sigmoid, and then this piece is the rectum, and then the anus is what actually exits the human body. And so kind of coming in here, now they're kind of showing you some of those muscle layers in there, so you can kind of see that. For digestive and urinary system that we're going to be doing for exam 4, there's two different sphincters, okay? Both of them have an internal sphincter and then an external sphincter. The internal is the involuntary for both. And it's the external that when you're getting potty trained as a small baby, as a child, you have to gain the control over that sphincter. And so lots of things can cause issues with that. Childbirth, different surgeries for, endometrial tissue removal, prostate removal, just anything like that can affect some of those nerves, and then that can start to affect somebody's bladder control, right? Sometimes like that, or even fecal control. As we get older, like older patients kind of lose some of those reflex controls, so a lot of elderly patients kind of lose some of that. So that internal sphincter, that's the one that initially activates, and it's going to respond to stretch, right? So these baroreceptors will pick up on the stretching of that rectum, and when it gets to a certain point, that activates that internal sphincter, right? And as a newborn, as a baby, you have no control over that external, so then everything just voids. The peristalsis comes and everything just comes out. You don't have really any choice in the matter. So what we end up having to do, though, is learn the control of that bigger external. And it still is kind of autonomic to us, right? You can say, ooh, I have to go number 2, I gotta go poop. And we know what that feels like. Well, that's your internal activating. And you can say, oh, but I'm in class, or I'm driving, or I'm doing this, I'm gonna hold it, right? And I'm gonna wait until later. Well, you holding it is you're controlling that external, and you're keeping that muscle tight, okay? And then when you finally go into the restroom, okay, again, kind of autonomic, you're relaxing that sphincter, then the peristalsis occurs, and then you push everything out. These big veins that are right here, those are the ones that can become enlarged and cause hemorrhoids, which can cause lots of bleeding, lots of issues. When they talk about cancers, and they talk about the anal verge, which is if you have cancer that bypasses that, it's usually pretty bad at that point. If the cancer stays like in here, it's a little better. But if it passes that verge, which is basically coming from the anus and then getting into the skin that's on the outside, if the cancer passes all the way out to here, it's usually a worse prognosis in that case. So lots of different terms that you might run across for this. And something we'll talk about too when it comes to thinking about the histology and all these different layers that we're gonna do. It's looking at the different tissue types, which we've already done before, right? We did epithelium, we did connective tissue, we did smooth muscle, right? But now when we get into doing this, you're gonna call those by a certain name. So as we change tissue types, it changes the look and it changes the name of the layer. So where those layer names come into, thinking about ulcers and how far they're actually penetrating into those layers of the stomach. It could indicate whether or not you've got a bleeding ulcer or something like that. But the biggest one is cancers, and being able to grade and look at how much that cancer, because if you end up having a colon cancer that's only affecting the epithelium, then that's easier to treat. They can go in there, get rid of the little polyp, done, right? But if it starts to encroach and get past so all of that whole light pink is a layer we call the mucosa. And there's actually 3 separate layers in that, right? So if it breaches that mucosa, now you're getting closer to the connective tissue that's got bigger blood vessels. So now your chance of metastasis starts going up. If that cancer, let's say, is growing through the muscle layers and then gets outside into this tissue, now you're gonna really be in a lot of trouble, right? So now that tumor can be growing somewhere out in the pelvic or abdominal cavity. Okay, so that's the layer names, and they will use those a lot of times when they're talking about cancer stuff. So liver, okay, liver sits on the right hand side. So the right lobe of your liver is going to be the biggest one. Don't get used to seeing right and left from this viewpoint, because we can also show it from underneath, right? So right side, left side. And then the gallbladder sits underneath, and it usually, like if we turn him over, and I kind of put him in my body like this, right? This is the front part, that's the anterior part, and then where that vena cava is coming down the back, that's against the back of my body wall, right? This was in my body, that's posterior. So look at where the gallbladder is. It's toward the front, okay? That's where the gallbladder usually lays, is kind of more anterior, because that's gonna help us to get to the last couple of lobes of the liver. So there's our diaphragm, and then on this, kind of see that white piece that they're showing right here? Something called the falciform ligament that keeps your liver attached to the front of the body wall, right? Your liver's not like roaming around in here. It's totally anchored in place up underneath the diaphragm. And then it's basically taking off your stomach, which would be coming in and covering up the tail and the body of the pancreas. And then you just barely have your duodenum coming in here. Well, then your transverse colon comes across all of this, right? So that's why, unless you take the stomach and the transverse colon, you don't see the pancreas. It's totally and completely hidden by those 2 things. So the head of our pancreas is right where we're gonna be meeting up with our duodenum. So now you've got your bile duct, that green one that comes down. The purple guys, that's your pancreatic ducts. That's the digestive enzyme stuff. Right? If you're talking hormones, it's going into the vasculature, totally and completely different. And then I've got another picture that'll kind of show this, but right where the bile duct and the pancreatic duct kind of come together, you get this little bulge, and that's going to be called an ampulla. Okay, so you guys saw that in 209 as the ampulla of your semicircular canals from the ear, right? When the ear canals go across, they were the same diameter, except they have that little bulgy piece kind of right there at the bottom. So just like papilla looks like this, okay, an ampulla is a bulging. We're also going to see another ampulla when we get to reproductive system, the ampulla of the vas deferens. Okay, so we're going to come across that again. So they call that the ampulla of Vader. So looking at the bottom side of the liver, and I actually like this one better. Okay, so if we remember that our vena cava is the back side of the liver, and that this side is our front side. That's our anterior, that's our posterior side. There's our gallbladder, there's your lovely triad that we've seen before, right? So it follows all the way up to what you can see with the naked eye. There's 2 other lobes. So right lobe, all of this, left lobe, all of this. Then you've got this little piece that's right next to the inferior vena cava, this tiny little piece right here, and then you've also got this piece that's kind of right next to the gallbladder. So when I was a student, anytime I could use like Latin roots, it always helped me to learn things better. Because these 2 lobes are going to sound super duper similar. Okay, you've got the quadrate lobe, and then the caudate, C-A-U-D. Okay, so caudate comes from the Latin root of caudal, which means tail. Right? So caudal, if you're going to have a tail as a human or an animal, would a tail be anterior or would a tail be posterior? would it be coming off your backside, right? So your caudate lobe is the one that's on the back part of the liver by your inferior vena cava. Okay, and then this one, if you use your imagination a little bit, but it just depends on the actual sort of section, it kind of has 4 sides to it, but not perfect rectangle, right? But it kind of looks like a rectangle, so quadrate for the 4 sides. That might be another way that if that's how you can remember it, that's fine. But for me, the caudate caudal posterior is totally how I remembered it, and it just the way that I used on exams. And so they're showing you that ampulla. So the green's the bile, purple's the pancreatic, and when they come together, they kind of make this little bulge, right? And so then if you look at this really close up and you think about gallstones that would be forming in that gallbladder, right? But then potentially getting pushed out because you have smooth muscle contractions that move the bile out. They're not going to go, oh shit, well, we're not supposed to move these stones out of here, duh, right? If it's a small, it can move the stone to come out, and it could potentially move it backwards to plug up some of these other bile ducts, which is what happened to my dad. Or if you have the really unfortunate happenstance of having it come down here and then retrograde and actually plug up the pancreatic duct. That is going to cause pancreatitis, and that can be life-threatening. Because if you block the ability of those digestive enzymes to make it out into that duodenum, they're going to start to back up, and they can actually start to activate in that lumen of that pancreatic duct, and then you start basically digesting your pancreas. Super fun, right? Not fun at all. So my dad was pretty lucky with his. I mean, yes, his gallbladder had some stones, but it actually moved this direction. And so what they had to do for my dad is they had to go through with the little grabby pinchy thing before they actually removed the gallbladder, because basically plugging up the bile flow makes the liver a little angry. You get some inflammation and all of that. So it's not a good idea if you think that you've got a stone. So before they ever even did my dad's surgery, they did an imaging. And they said, oh yeah, we can see a stone that is plugging up one of the bile ducts. So they had to go in with the little pinchy tool, the little pinchy grabby tool, and go in and actually pull out that stone, let the bile kind of flow. And I think he only had to wait like a day or two, but let the bile start flowing, let the inflammation go down, then they went in and took the gallbladder out. But if you end up trying to do a gallbladder removal on a patient that has a stone that's actually plugging up the bile ducts, it can make their recovery a lot longer and all of that. So they want to go in there and grab that sucker out. And so if you feel, and you know, the symptoms of pancreatitis and gallbladder stones are almost identical. They're almost exactly the same. So if you're feeling like a lot of pain, advocate for yourself and get imaging. Okay, or don't just assume it's something that'll go away. Don't assume it's stress. Don't assume it is, you know, just I ate spicy food and now my stomach's a little upset. If it's really severe pain, go to the student health center, get it checked out. One of my super good friends ended up having his pancreatic duct blocked, but he was going to school for pre-med. And so he was right before a bunch of exams, and he was like, oh, I can't be dealing with this right now. And he waited until he literally ended up pretty much passing out from the pain, and his wife is like taking him down to the ER. But by that point, the pancreatitis was in full bloom, and for about a year after that, he went back and forth from here to Denver and ended up with multiple organ failures. He ended up with respiratory issues, with cardiovascular issues because of how close this sits to the diaphragm. Like he had to be intubated multiple times because his respiratory system kind of shut down. And he survived, but now he's got lifelong health issues because of it. He's only got, I think, just a few % of his acinar cells are even active. And so his islets have been almost totally and completely destroyed. He's on so many medications with digestive enzymes and things to help him to try to control blood glucose. But the worst part was that when he was having the respiratory issues and all of that, it affected his cognitive abilities. So he tried to come back to school after the year, and he was back here, and he couldn't do it. He's like, I literally cannot, and it was such a hard thing for him, because he was like the straight A student, bam, 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 acing exams, getting ready to start studying for like, you know, MCATs and all of that, And this just knocked him out. He's like, there's no way that I could do this. And he goes, my energy won't allow me to even be a doctor. Like, he was gonna be a surgeon. He's like, I don't have the stamina anymore to even do it. But he kicks himself because he's like, if I would have went to the doctor when that pain first started, they could have caught it super early and he probably would have been fine. He probably would have been totally, completely fine. So he's, that's one of those things where you look back and you're like, shit, should have made a better choice. But I mean, your pancreas is gone. Like, there's literally nothing that you can do about it at that point. So if you feel severe pain that is preventing you from doing things, go to the Student Health Center for the love of all things holy. All they would have had to have done was do an imaging, and they would have seen that little gallstone plugging up his pancreatic duct. So yeah, kind of a bummer. And then I don't ask questions about like the pathway, but just kind of reminding ourselves that bile initially comes from the liver, moves through the bile ducts, goes to the gallbladder, and then comes out. But with all those ducts in there, it's easy for those gallstones to come moving around because you've got smooth muscle contractions, right? So you can't just say, oh, they're just gonna hang out in my gallbladder until I take the stupid thing out. They get out and move, that's gonna cause you a lot more issues because you've got a lot of ducts kind of coming in. Cool. And then next time we're gonna focus in and we're gonna look at the layers. So this is where you're gonna get more practice with